Femoral hernia is herniation of intra-abdominal contents through femoral canal. It's more common in females compared to males, the reason of which we will see now. And its occurrence in females to male ratio is 2:1. Coming to surgical anatomy of femoral canal extends from femoral ring to the saphenous opening. Femoral ring is bounded anteriorly by inguinal ligament, posteriorly by ligament of Cooper and iliopectineal ligament. Ligament of Cooper is the thickening of periosteum over the pectineum and also the pectineal fascia. This is ligament of Cooper, and along with iliopectineal ligament of Cooper forms the posterior boundary of femoral ring. Medially, we have lacunar ligament as a boundary of femoral ring. Laterally, we have septa separating femoral canal from femoral vein. This is about femoral ring. Starting from femoral ring, the canal extends up to the saphenous opening, saphenous ring, where our greater saphenous vein pierces the deep fascia and drains into the femoral vein. The saphenous ring is present 4 cm below and lateral to pubic tubercle. And inside this femoral canal, we have fat, lymphatics, and lymph node of Cloquet. This is about the surgical anatomy of femoral canal. Idiopathophysiology of this condition, femoral hernia, causes wide femoral canal and multiple pregnancy. Multiple pregnancy because it increases the intra-abdominal pressure and compression over the femoral vein, which causes dilation of femoral compression over the inferior vena cava, and the pressure is transmitted downwards, which causes dilation of femoral vein into the adjacent femoral canal, weakening the femoral canal. So, multiparity is a risk factor for developing femoral hernia. The femoral hernia, it starts from the femoral ring, and the intra-abdominal contents will descend from femoral ring down to the saphenous opening. And then after passing through saphenous opening, it comes out through the saphenous opening and it occupies the surrounding area, loose areolar tissue. It is a retort shape. Here you can see it starts from femoral ring, descends down to the saphenous opening, and then it occupies the loose areolar tissue outside the femoral saphenous opening. We know that this femoral hernia has a narrow neck at the femoral ring, so it is more prone for obstruction and strangulation. The clinical manifestation of this condition is the patient presents with swelling, which is, and medial we have the inguinal hernia presenting as swelling. Below and lateral to pubic tubercle we have femoral hernia presenting as swelling. This swelling is reducible. We can feel the gurgling sound while reducing the contents, and also the swelling is cough impulse positive. We have the gauze sign, which is dilation of superficial epigastric vein and circumflex iliac vein due to the compression of these veins by the swelling, the femoral hernia. We know that this hernia is more prone for obstruction and strangulation. So in 40% of patients can develop obstruction and strangulation. They present with swelling which is painful, tender, and inflamed, and the swelling will be irreducible at this stage. And the patient will have the features of intestinal obstruction like obstipation, which is inability to pass flatus and the stools, and there is abdominal distension also associated with vomiting. The complications are obstruction, strangulation. We already saw. Then we have another complication of femoral hernia is Richter's hernia, where the circumference of the bowel is the content of the hernia. The circumference of the bowel will be the content of this femoral hernia passing through the femoral ring. So since it has narrow neck, it's more prone for strangulation. This patients with Richter's hernia usually present with hernia which is tense and tender and irreducible due to obstruction and strangulation. These patients will not have the features of intestinal obstruction because complete lumen of intestine is not occluded. They will only present with bloody diarrhea because of the necrosis of the part of the bowel. And later the strangulated part can go into gangrenous changes, and it can lead on to peritonitis. The Richter's hernia will treat by the high operation, that is McEvidy's operation and Lothison's operations, which we'll see. Now coming to management of this condition, the surgery is the management of this condition, femoral hernia. We have three surgeries, that is low operation of Lockwood, and then McEvidy's high operation and Lothison's operation. In low operation of Lockwood, we perform it in uncomplicated hernia, where the incision is given over the swelling. The sac is dissected from below, and then we reach the neck in the femoral ring. We ligate it, followed by that we suture the inguinal ligament to the Cooper's ligament, which is the posterior part of this femoral ring, so that this hernia doesn't recur. While performing this operation, in some patients, around 10 to 20% of patients, we can encounter an abnormal obturator artery. If we are not careful, we can injure this, leading to torrential bleeding. This abnormal obturator artery usually crosses the ligament of Cooper, which is the posterior part of femoral ring. If we have the strangulated femoral hernia, we can't perform this Lockwood operation, low operation of Lockwood, because we are going from below. While going from below, the gangrenous bowel, we can't see it fully, and we can push it, or the full visualization of the contents of hernia is not possible in Lockwood operation. So we'll perform McEvedy high operation in case of strangulated femoral hernia. In McEvedy's high operation, a vertical incision is placed. It extends over the femoral canal. The vertical incision is placed over the femoral canal. This vertical incision will extend beyond the inguinal ligament. Following this, we dissect the sac from below and the neck from above, meaning the hernial contents, the hernial sac is dissected from both above and below, and then this sac is dissected out. And then following this, the defect is repaired from above. This is McEvedy's high operation. In McEvedy's high operation, we saw it's where an vertical incision is given. Following that, the dissection is done both from above and below, and then we'll dissect the hernial sac. Following that, we perform the repair from above using the suture. This about the McEvedy's high operation done in strangulated femoral hernia. Then we have Lothison's operation. Lothison's operation, we perform the inguinal canal approach, similar to the inguinal hernia operation. We perform this, where we go through the fascia transversalis, and then we visualize the neck of the hernia, that is at the femoral ring. Then the hernial contents is dissected from above. Following herniotomy, we perform Lothison's repair, that is suturing of conjoint tendon with the iliopectineal ligament, which forms the posterior part of the femoral ring. This about the Lothison's operation, McEvedy's operation, and low operation of Lockwood. To summarize, femoral hernia is the herniation of intra-abdominal contents to femoral canal. We saw the surgical anatomy. It extends from femoral ring to saphenous opening. The contents are lymph node of Cloquet, fat, and lymphatics. The etiopathophysiology we have cause is wide femoral hernia and multiple pregnancies. The hernial sac, it starts from femoral ring, descend downwards to the saphenous opening, and then it escapes to loose areolar tissue. It characteristically have the retort shape, which is this shape. It has a narrow neck, so it is more prone for obstruction and strangulation. The patient presents with swelling, which is below and lateral to the pubic tubercle. On examination, it is reducible swelling, where we can feel the gurgling sound while reducing because the bowel will be the content of the hernia. Then we can see the cough impulse positivity in this swelling. If the patient has obstruction and strangulation, we see painful, tender, inflamed, and irreducible swelling with features of intestinal obstruction like obstipation and distension. The other complication of this femoral hernia along with obstruction and strangulation is Richter's hernia. The management of this condition we have in uncomplicated hernia, low operation of Lockwood; in strangulated femoral hernia, McEvedy high operation, and Lothison's operation. Thank you for listening.